what I would like to do today is be your guide in a journey that goes from the concept of cancer gene therapy for solid tumors to the reality in patients. So this is a very, very broad area of research. So I apologize because I will not be able to get into details. I will just comment the main concepts and give some examples that I think are more didactic from the literature. So the general strategies for cancer gene therapy are not new. From the very beginning, we knew that transfer of genes can be useful for treating cancer. And all these strategies, as I said, have been there. The advances that we are now experiencing are probably not because there are new strategies, just because we have new tools and advanced methods to really get these objectives. So gene therapy, gene transfer could cure cancer by interfering with oncogenic pathways, for instance, restoration of tumor suppressor genes, inhibition of oncogenes, or expression of anti-angiogenic genes. We can also take a more direct approach against cancer cells to destroy them selectively by selective expression of toxic genes, or using the approach that Dr. Bonini already explained to you, this gene-directed enzyme prodrug therapy, also called suicide gene therapy. We could actually do the opposite. We could just focus on the normal bone marrow and transfer genes that will protect it from high doses of chemotherapy, so we can give these high doses and that will be more effective against the tumor. Then we have a very big area of gene therapy, ways to stimulate immune responses against tumor using transfer of genes. And then we can also use viruses and their genes to try to destroy cancer cells. So what I would like to do is to explain or discuss with you the problems that all these strategies have encountered over the time, and what kind of solutions or approaches are being developed to really try to overcome these obstacles. And we have to keep in mind that, this journey sometimes is a two-way journey, because in many instances, what we'll learn from clinical trials make us go back to the lab to try to solve these issues. And finally, I have to say that there are many other obstacles that are not scientific, but that can also be a problem, but that's another subject. So particularly about solid tumors, there are specific challenges for gene therapy. Solid tumors have an aberrant vascularization, they have a high interstitial pressure, and this makes it difficult for gene therapy products to get into tumors. Tumors are also physically heterogenic. They are a mixture of cancer cells, stromal cells, extracellular matrix, necrosis, and this also is difficult for the function of gene therapy products. They are genetically unstable, and that also can make the tumors change their properties over time. So maybe gene therapy that works at the beginning can stop working as the tumor progresses. So, but what are really the main limitations of cancer gene therapy right now? One of the main ones is the efficacy of gene transfer, because right now, only a fraction of cancer cells can be reached by our vehicles for gene therapy, by our vectors. Also, the duration of gene expression. For some approaches, it would be good to have expression of the therapeutic gene for a long time, and that, with some vectors, that's not possible. Intensity of expression can also be a problem, especially with the early generation of vectors that we had. Biodistribution, sometimes the vector gets to organs or tissues that instead of giving us efficacy, are giving us toxicity. Another approach also focusing on the dendritic cells is to express several genes, some of them, like gene CSF of IL-2, IL-4, for differentiation of the dendritic cells, and together with other genes that, in this case, are antigens, tumor antigens, in this case for melanoma. So using a tricistronic lentiviral vector, we can transduce the dendritic cells. And this has been worked out in the clinical setting. So you can harvest the cells from the patient. You can do the infection with lentiviruses, and you can cryopreserve the cells. And the cells, after recovery, they retain the function. This is demonstrated here by a functional assay, demonstrating that these cells can protect mice from a challenge from melanoma cell line and increase survival. So this is two ways in which gene therapy can increase the function of the dendritic cells. But then now a field that is expanding rapidly is the field of adoptive cell transfer. And again, thanks to Dr. Bonini, I don't have to explain you again what is the rationale behind using these artificial T-cell receptors or these chimeric antigen receptors. So I would like to give you a futuristic view about this field, because really engineering T-cells has a lot of potential. You can think about transferring not only one antigen receptor, chimeric antigen receptor, but probably two in the same cell, one for activation signal and another one for a coactivation signal. This will increase the specificity of this approach, because probably normal cells, if any, they will only express one of these antigens. You can also transfer receptors for chemokines that are produced in the tumor. So this will improve the homing of the effector cells. Very importantly, you can express cytokines that will stimulate the function and the proliferation of these T cells, like IL-12, for instance. You can transfer pro-survival genes. You can transfer surface antigens that will allow you to track these T cells. For instance, if you transfer CD20. And also, this will allow you to eliminate these cells with antibodies like rituximab in case you see toxicity. And then also, you can use these new suicide genes as a safety measurement in case you see toxicity. All these modifications, of course, right now, have never been tested together, but some combinations are being used, and they are showing good effects. For instance, in this case, the T cells were transduced with two lentiviral vectors. One of them expressed the antigen, the CAR, the chimeric antigen receptor against VEGF receptor 2, which is expressed in the tumor vasculature. And the other one will express IL-12 under the control of a promoter that will be active when the cells are stimulated. And what they found in preclinical models is that they can have, using very small amount of cells, they can have a very robust anti-tumor effect only when the cells are transduced with these two vectors together, meaning that this IL-12 effect is an autocrine effect. This is moving into the clinic, but right now, the main problem that they are facing is toxicity mediated with IL-12. So IL-12 is a very interesting molecule for stimulating the immune response. The problem is that it's toxic. So another approach is to use long-term expression vectors, either AAV or high-capacity adenoviral vectors, to obtain controlled expression of IL-12. And this can be done using inducible systems. In these systems, you have expression of a transactivator that by itself is inactive, but only in the presence of an inducer, it dimerizes, and then it can bind and work as a transition factor that activates the expression of the transgene, in this case, IL-12. And we have demonstrated that using these vectors in vivo, you can control the intensity of expression and also the timing. You can decide how much and when and you express IL-12. So finally, I would like to present you some an overview about oncolytic viruses. The concept of oncolytic viruses are viruses that either naturally or genetically or by genetical modifications, they can replicate specifically in cancer cells and destroy them. But not only that, but also when they replicate and they finish the lytic cycle, they release new particles that can infect neighboring cells and amplify the effect. There are many viruses that can be adapted as oncolytic viruses. Actually, some of them have already an intrinsic preference for replicating in tumor cells. In general, this is because these viruses are normally attenuated in normal cells, and just in cancer cells, they find the right environment for replication. On other cases, these viruses like adenovirus, herpes, or vaccinia, they have to be genetically modified to render them tumor-specific. And there are too many ways to make these viruses specific for tumors. One of them is to control the expression of viral genes that are needed for replication. This can be done by placing these genes under the control of tumor-specific promoters or tissue-specific promoters. But another way that is now being developed is to use to inhibit expression of these genes in normal cells using targets for microRNAs. Another way to gain selectivity is to make deletions of certain genes that the virus needs for replication in normal cells, but they are dispensable in cancer cells. And well, there are just some examples in adenovirus, herpes, and pox virus, but I'm not going to get into detail about this. These are just functions that the virus doesn't need in tumor cells. So oncolytic viruses have been developed for many years, and the result of clinical trials so far has demonstrated that they are safe, but the main problem of these viruses, at least as monotherapy, is efficacy. Because oncolytic viruses, they face many challenges in solid tumors. Many of these limitations are the ones that I already mentioned to you. But apart from all these things, the immune system is a big barrier for oncolytic viruses. What I mean with this is that this amplification of the effect that is so important in these viruses is really limited in an immunocompetent host. So the field now is looking for ways to increase the efficacy of these vectors by incorporating therapeutic genes, for instance, suicide genes, radiosensitizers, pro-apoptotic genes, anti-angiogenic genes, or genes that will improve biodistribution, like genes that degrade the extracellular matrix. And a very intense area of research is to incorporate immunostimulatory cytokines into these vectors. Because what is clear is that in oncolytic viruses, you have to collaborate with the immune system. It's very difficult to avoid immune response against oncolytic viruses. So it's better to have the immune system on your side. This is an example of how an oncolytic virus can be very effective in an immunocompromised animal, like these nude mice. But a similar virus, if you test it in a permissive immunocompetent model, like the Syrian hamster, it virtually has no effect. But if the same virus now expresses a cytokine, an immunostimulatory cytokine like GNCSF, then you start to see an effect. So there are many cytokines that are being evaluated as transgenes in oncolytic viruses, like GNCSF, CD40 ligands, anti-CTL4, IL-12, IL-15, etc. So the rationale behind these approaches is that the oncolytic virus will provide danger signals. I mean, the body will sense that there is a replicating virus in a tissue, and it will mobilize all the resources to attack it. This might counteract the immunosuppressive microenvironment of tumors. And also, the direct oncolysis of the vector, even if it is limited, it can release some antigens, tumor antigens, that can direct the immune system towards these antigens. And also, the transgenes, of course, can stimulate the immune system further. So I will just show you two examples of oncolytic viruses that have reached far in the clinical testing, phase 2, phase 3 trials, and they are showing promising results. One of them is a herpes virus expressing gene CSF. Herpes virus is an enveloped virus with a long genome and a strong cytopathic effect. In this product, the virus was attenuated by deletions as I mentioned you before, to make this virus selective for replication in cancer cells. And the phase 2 clinical trials in metastatic this is melanoma, metastatic melanoma. They show that by intratumoral injections of this virus every 2 weeks, up to 24 doses, they saw some complete responses. They saw an increase in survival versus historical controls. And importantly, they saw responses in non-injected areas, which means that a systemic effect is being achieved. And this was observed even in the absence of elevation of GNCSF in serum, which means that the local effect of the virus is producing a systemic effect. Recently, the result of a phase 3 clinical trial also in melanoma. This is still going, but the interim results are promising because they could demonstrate that an interesting complete response rate and at least almost 20% durable response rate, which suggests that this is being somehow effective and clearly more effective than giving the GNCSF as a recombinant protein. Another oncolytic virus that is reaching far in the clinical trials is also expressing GNCSF, but in this case, it's a vaccinia virus. This virus is even more complex. It's a huge virus it's a big genome, very strong cytolytic effect, and it has interesting properties because the size of the particles is so big that it's believed that maybe it has a preferential homing in the tumors because tumors have a more leaky vasculature. So what they found in these trials, in this phase 1 trial, in this case they administer the virus also intratumorally. And in this case, in the high dose cohorts, they could see elevations in GNCSF, which correlated in elevations in neutrophils, which means that this transgene is being active. In this case, they reached the maximum tolerated dose. And now they are going to phase 2 clinical trials. In this one, they compare high dose versus low dose of viruses, and they could see some suggestion of therapeutic effect because the survival in the high dose cohort was higher than in the low dose cohort. So really, these viruses are doing something in the progression of tumors. But I want to point you some important issue here that could compromise the further advancement of this therapy. And it's the fact that in these clinical trials, for instance, the one in the vaccinia virus, what they saw is that very early after injection of the first dose, they saw an elevation of neutralizing antibodies against the virus. And now it's somehow controversial if these neutralizing antibodies can block the efficacy of further intratumoral administrations. But the fact is that looking at the published data, you can see here that when they measure the genomes of the virus in blood, after the first cycle, you see that the genomes, of course, they go down after infection because the virus is clear, but then there is a peak after several hours and days, which is very suggestive of replication of the virus in the tumor. But in the subsequent cycles, they don't see these peaks, which suggests that the neutralizing antibodies are really blocking the efficacy of repeated administrations. So one potential way to overcome this obstacle would be to use carrier cells to deliver these viruses. In this approach, you infect the cells ex vivo with the virus, and then you will inject the infected cells. Since the virus, since it takes some time for the virus to replicate, this is the time that the cells have to reach the tumor. And inside the tumor, they will release their viral payload. This has many potential advantages. You can then avoid the effect of neutralizing antibodies and then give different doses of viruses. And also, these carrier cells can have additive effects, especially if you use, for instance, T cells or mesenchymal stem cells, as I will show you in the next presentation. This is a very small clinical trial done in neuroblastoma patients, in which they used an oncolytic adenovirus, and they used mesenchymal stem cells as carrier cells. What they found in this trial is that, at least in one of the patients, they see a very, very intense partial response that then it was made durable after standard therapy. And taking into account the amount of cells that can really reach the tumor and the amount of virus there, it is what they think is that the effect is mediated by an immune response. Also because they saw a peak in the T cells in the patient, especially in those patients that respond to the treatment. Now more clinical trials have been done, and I think we will have a very interesting talk in this Congress about this approach. So I bring to you this data because I think what is important is to look at the interplay between immune responses against viruses and against tumors when you use oncolytic viruses. And just to finish, I will present you some studies done in patients to just look at this issue. In this case, this is a compassionate use of viruses in cancer patients. They used also a non-oncolytic adenovirus directly into the tumor. And I show you here just a provocative example, which is, of course, this has to be demonstrated. But the thing is that when you look to a patient that got a complete response from an ovarian cancer, what you see here is the stimulation of T cell responses against sorry, I cannot see very well. This is, against the antigen, against the viral antigens. You see in all the cases an stimulation of antiviral responses against the virus. And in some cases, you see anti-tumor responses. This is responses against a tumor antigen surviving. And in some cases, these responses are of the same magnitude. This is just the early spot. The problem is that in most of the cases, what you see is very strong responses against the virus and very limited responses against the tumor. And so we need to really find ways to tip this balance towards anti-tumor responses, not antiviral responses. And the problem is that if we keep giving repeated doses of the same virus over time, probably what we are really favoring is this kind of responses. So a very interesting approach that has been recently published is to use a sequential combination of antigenically different viruses. The rationale is that using this approach, the only antigen that will be the same over time, over different administrations, will be the viral antigens, not the tumor antigens. So we can really make a prime boost vaccination against viral antigens, sorry, against tumor antigens, not viral antigens. And this has been demonstrated really in preclinical models in which if you give 6 doses of the same virus, you don't see practically an effect in this syngenic immunocompetent model. But if you give first adenovirus and then vaccinia virus, you see a very good effect. Interestingly, the order is important because if you give first the adenovirus and then the vaccinia, it works, but if you do the opposite, it doesn't work. And just to finish, I will finish saying that these kind of approaches, what we'll really need is partnership between companies. I mean, really, this is needed to really rescue the patients from their disease. It's just like in the high mountains, when some mountaineer is in trouble, everybody forgets about their own interests and objectives and go together to rescue the companion. Now, cancer patients are really in trouble, so we need collaboration with companies maybe to really to put forward these kind of approaches. So thank you very much. Any question?
Thank you, Ruben. Any questions? So I have a question. I was struck to see how much the immunoresponses, the clinical responses obtained with GVAX were improved when this approach was combined with anti-PD-1, anti-PD-1L antibodies. But then on the other hand, if we take out the break of immunity, we might actually increase the viral immunoresponses. How should we use these new tools?
Yeah, that's a very important issue about immunotherapy. I think, of course, it will depend on the tumor. It will depend on the tumor, and there is no easy response about that. I mean, I think actually, when you use only the break, the anti-PD-L1, it doesn't work so well anyway. So I think the key point will be to have a very, probably a very efficient way to stimulate really a specific immune response against the tumor, and then use these ways to avoid the break very carefully. So, but I think it's very early to know what will be the end.
Another question?
So thank you for your nice presentation. Well, I previously saw like the different serotype of the adenovirus they used for avoiding the immune response, like clearance. But these new approaches, like with the vaccine and adeno, and also I saw like with semiliquiporous and adeno previously, it was interesting. So do you have any idea how it comes that then, well, you use adeno for the first and the vaccine for the next, it works, but the other way around, it doesn't? I'm curious, yeah.
So you mean why?
Why, yeah.
Well, this is something that is being investigated now. I mean, probably what happens is that some viruses are better to prime an immune response because they are maybe more immunogenic. And these ones maybe are the ones that have to be used first, and then other ones to really boost this immunity. But this is a very new field, and still many new combinations have to be tested.
Okay, and does it have some advantages in compared to what I said, like primarily different strain of the adenovirus or maybe adeno-associated?
I think so, because when you do different strains of the same virus, you will still have many common antigens.
True.
I think it's much better to use viruses that are completely different antigenically for this approach.
Thanks.